It's May the 10th, 2025. This is the Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor of RoomNow.com. This week, I'm going to talk about triple positivity. I'm going to say some things I never thought I'd say about a true underlying pathogenesis to CRPS. Oh my goodness. And now I'm really going to go out on a limb and say something nice about vitamin D. I think you've heard me go off on vitamin D in the past. But let's get into the news. You know, this is the first full week of our Lupus campaign called Lupus Unlocked. You have the keys to mastery. So we have a lot of lupus content. But before we get into that, we had a lot of other news on the website this week. I want to start with congratulations to Dr. Virginia Pasquale, a good friend, great mentor, exemplary pediatric rheumatologist and scientist who's been elected to the American Academy of Arts and Sciences. She's now at the Weill Cornell School of Medicine doing translational research as only she can. Congratulations to Virginia. An interesting meta-analysis of vasculitis and interstitial lung disease, 8 studies, 650 patients, shows these patients have significant mortality, and the mortality is related to age, having a past history of smoking, a UIP pattern, history of exacerbations, and being the microscopic polyangiitis type. Again, ILD, when it happens on any of our diseases, is just ups the odds on bad outcomes. An international committee called the IMAX Group, International Myositis Assessment and Clinical Studies Group. God bless you for the work that you do. They had a consensus study as only they could and came away with the research that says the new preferred term, I didn't know if this was an issue, but now it's clear, for the antisynthetase syndrome is the antisynthetase syndrome, and the preferred abbreviation for the antisynthetase syndrome is ASYS. A capital S, lowercase y, capital S. This was chosen over AS, and I can't imagine why. So ASYS is the abbreviation, antisynthetase is the syndrome. A microbiome study on patients with complex regional pain syndromes. These are difficult to manage pain patients. I don't think we understand the pathogenesis of this. They did a 16S RNA amplification to look at the taxa in the stool samples of 53 patients compared to 52 controls and showed a clear-cut difference in microbiome and also in short-chain fatty acid levels between CRPS and controls with over 90% accuracy. I can't make anything of this other than it's a head scratcher, and I think it's great when you can find data like this. I think it needs to be looked at by others and delved into in a high volume research, even randomized control way, with a lot of blinding. But if this is true, imagine, you can't treat their pain. They're refractory. I don't know where to start. I don't know when to end. But if you could manipulate the microbiome, wow, that would be incredible. An eye-opener, and I think you probably know this, what do you do in patients who require lung transplant? Can you do lung transplant in patients with connective tissue disease? A study of 42 patients with long-standing RA complicated by ILD, and the ILD complication actually started within a year in most of those patients. These patients were collected, 42, over a 16-year period. The survival was not good, although after transplant, the 1-year survival was 88%. The median survival was 5.3 years, which, by the way, these numbers on survival are the same as lung transplants in other patients with connective tissue disease and also in non-connective tissue disease patients who require lung transplants. So our patients do just as good as others, and hence ILD in our patients with RA is not a contraindication to lung transplantation. You could say the same for other rheumatic diseases. The mortality overall was 43%. It was higher in people who had the UIP pattern on CT scan. A single center study of almost 140 patients looked at the value of doing CRP antibodies in addition to rheumatoid factor and ACPA. And they showed that patients who were triple positive had worse disease. They had worse activity. They had significantly higher TJCs compared to single positivity. They also had higher pain scores, higher -28 CRPs, higher SED rates, higher ACPA levels, but lower rheumatoid factor. And didn't matter if you were single, double, or triple positive. It didn't make a difference in bone markers and also in bone erosions. But nonetheless, more severe disease. So I don't routinely do CAR-P antibodies. You can do them. It performs just as well as ACPA, maybe not as well as ACPA, but the question is, do you get something more? And I don't believe that patients who are seronegative that you can do CAR-P antibodies or 14338 for that matter, and find a whole bunch of people who are seropositive for those markers when they're negative for RF and ACPA. You'll find a few. But I think I would encourage each of you to find your own way here and to look at your own experience. An interesting case report. It's a case series, but I think it's interesting because of the claim. 7 patients with established long-standing RA, refractory to disease, with moderate to severe RA and nodules, who were started on either tofacitinib or upadacitinib. 5 out of the 7 had complete resolution of their nodules. What? And 1 other had a reduction in nodule size, and these nodule changes took 3 to 12 months, generally 6 to 12 months for most of the patients on JAK inhibitor therapy. Could that be yet another benefit of JAK inhibition? I don't think that's been well studied in clinical trials, and this case report, I think, should lead people to go back and look at that data if in fact it was studied. But honestly, having done lots of RA clinical trials in the past, you note whether they have nodules going in, but you don't measure nodules during a trial, because the question is, how do you measure them? You know, I squeezed them and they were this big when I started and they were this smaller when I ended. Again, nodule burden and quantifying it is a difficult thing to do. But I think it's really cool. A Finnish birth cohort shows us something about the natural history of osteoarthritis of the knee. So this is a birth cohort that started in 1986, and they followed these patients for many, many years. They were all obviously asymptomatic when they were enrolled, but early on, they developed cartilage defects at the patellofemoral joint, 56%, tibiofemoral joint, and 25%. They had some osteophytes that were seen in 17 to 20%. Again, most of these patients who had these MRI-only abnormalities had high BMIs, and that might be the reason for it, but it antedated and predicted future knee OA. Tells you that this is a long-standing process that starts. I mean, my knees, I ended up having knee replacement when I was 60. I blew out my knee playing football when I was 17. I continued to play sports on both knees that were damaged, for the next 10, 15 years, and I got pretty bad knee OA that required bilateral knee replacement, and it changed my life, and it was wonderful. But I'm sure I started my damage back when I was in my teens, and it was probably from my activity, more so than anything else. Cool study that makes me eat crow. It's reported in JAMA. It's called the DELAY study, D-L-A-Y, as in delay the onset of disease with multiple sclerosis. This is a high-dose vitamin C trial, double-blind, randomized, placebo-controlled, where they get vitamin D3, 100,000 units, given every 2 weeks for 2 years. And the patients that were enrolled were people who had sort of preclinical MS, what's called clinically isolated syndrome. And they basically found that disease activity over time was less than those on vitamin D, 60%, versus those on placebo, 74%, that being significant. A 34% reduction overall. They had significantly better MRIs. They had significantly less cases of relapsing remitting MS in the end. The time to develop disease activity took longer on vitamin D, 432 days versus 224 days, again, that being significant. This data kind of jives with Karen Kostenbatter's data about Vital preventing autoimmune disease, which I have some concerns about the methodologies, especially, again, the Vital study was given vitamin D to look at cancer and cardiovascular outcomes where it had no effect. But the secondary analyses that was done in the Vital study showed it looks like it might have had some effect. This is encouraging data. And yes, I have some doubts about all the claims on vitamin D. I don't believe most of them. I think it's a marker for most of us who develop some kind of illness. It's associated with everything, but not generally known that vitamin D supplementation prevents all the things that it's been linked to. Those are my gripes. An interesting study from Michelle Petrie's group in Arthritis Care and Research shows that patients who have very low or very high vitamin D, 25 hydroxy vitamin D levels, had worse and more adverse pregnancy outcomes. This includes miscarriages, preterm deliveries. Again, they were significantly increased in people with very low levels or people with very high levels, which is an odd thing. Anyway, the patients who had the lowest risk of these adverse pregnancy outcomes were those who had, and this is the recommended level to shoot for, is 40 to 60 nanograms per ml. So you should be doing vitamin D levels at conception and maybe during pregnancy if you'd like to maybe affect some of the outcomes here. Another really cool study recently in New England Journal was on NASH or NAFLD, which is now called MASH, Metabolic Dysfunction Associated Steatohepatitis. Double-blind, randomized, placebo-controlled trial, 1,100 patients, all with a BMI of 34 to 35 and having being at risk, showed significant reductions in the risk and the outcomes of patients as far as their MASH. Another cool benefit to GLP-1s in the world of medicine. What about the SGLT2 inhibitors? An emulation trial was published this week about SGLT2 inhibitors in patients with lupus. So these are the sodium glucose transporter inhibitors. This was a clinical trial emulation using insurance claims data, 2,100 lupus patients versus 2,100 controls, and they're all lupus patients, I guess, and they're either on diabetic medicines, the SGLT2 inhibitors, or not. And guess what? They significantly reduce the risk of many cardiorenal complications and serious outcomes that are seen in lupus. This includes acute kidney injury, chronic kidney disease, end-stage renal disease, emergency room visits, heart failure, and even sepsis. Again, impressive. So good news for your patients who have lupus and who require either an SGLT2 or a GLP-1. Janet Pope wrote an editorial for the journal and also for Room Now during our lupus campaign, asking the question, are emulation trials real or fake? And she kind of reviews the study and reviews that there are channeling biases associated with trying to model data after the trial you'd like to do but can't do. So you use pre-existing data and you retrospectively emulate that trial. She likes the results. She believes the results. She wonders, though, about emulation trials. You'll be seeing a lot of them in the future. I think it's good to maybe review that. Again, this month is Lupus Month worldwide. There are a lot of good lupus conferences out there. The biggest one is in Toronto on the 20th through 24th. I think that all the lupus mavens are going to be there. We have a campaign on Room Now and a lot of lupus content being covered. Here's some of the reports this week. A retrospective study of 131 children with lupus looked specifically at lymphopenia. We know it's a criterion for the diagnostic criteria But what is its value as an independent variable? In their 131 patients, then it was lymphopenia was found in 53%, highly correlated with double-stranded DNA antibody titers, highly correlated with disease activity with a correlation coefficient of 0.63. That's pretty high. Lymphopenia was associated with more nephritis, 72%, more hypertension, 24%, more leukopenia, that goes together, 36%, and more neuropsychiatric lupus. So I've always been to me, that's the hidden gem in diagnosing lupus. You know, they may not have leukopenia, but do the math and find they have lymphopenia, boom, you've got another criterion. Another lab test having significance in the world of lupus is procalcitonin. I might have talked about this last week, I can't remember, but anyway, in this study of 116 juvenile lupus patients had serious bacterial infections in 17%, procalcitonin was a better predictor than other things that we look at, including sed-rate CRP, neutrophil lymphocyte ratio, platelet to lymphocyte ratio. An article this week appeared in the literature about whether you should be withdrawing steroids or immunosuppressives should you want to withdraw either. And in the study, it was basically a single center randomized controlled trial that looked to answer the question, is withdrawing immunosuppressants non-inferior to withdrawing steroids? And in fact, it was non-inferior. So there isn't a preference of one over the other. I know you'd like this kind of paper, as I would, to tell us which one should I withdraw, which is the smarter regimen. I'm going to get to that in a second with another report. But this one says you have to choose, and you have to choose based on, you have to sort of individualize it to the patient, their situation, which drug they need better, which drug they hurt the most, they hate the most, etc. A great article this week by Mike Putman from the University of Wisconsin, where he talks about PJP prophylaxis in lupus. Should you do it or not? He says, I'll pass. Check it out. He'll give you a good history as to why he doesn't and the rationale behind that. And I kind of agree with him. I don't put many of my patients on PJP prophylaxis. For me, it's usually ANCA-associated vasculitis who are on multiple immunosuppressants and high-dose steroids. Those are ones that get highest risk. And also patients on rituximab in general are at higher risk for PJP. Great blog by Dr. David Pazetsky from Duke. I think one of our leaders in lupus, certainly incredibly well known for his research on serologies and double-stranded DNA. And the title of his blog is From DNA to PGA. And he's talking about patient sort of outcomes. In this blog, he gives you his history in getting into lupus and serologies, and then how he had to pivot and start talking about type 2 SLE. He's going to lecture on that at the lupus meeting coming up in a few weeks, where he and his coworkers at Duke came up with this idea that there's two types of lupus. One that's firmly rooted in inflammation, nephritis, anti-double-stranded DNA antibodies, that's type 1. And then there's this other type of lupus, type 2, characterized by pain, fatigue, mood disturbances, and brain fog. And that's the fibromyalgia of lupus, or what he called lupus-associated nociplasticity. It's important to know because it clearly is going to change how you treat this. Another great blog and article by Guillermo Ruiz Irastorza from the University of Madrid. Guillermo does a great job of talking about when to start, how to follow, and when to stop, and how to stop steroids in your lupus patients. I think it's a really good review article. He ends it with a few bullets like, use hydroxychloroquine to basically help lower your needs for steroids. And everybody should be on hydroxychloroquine. Adjust the induction therapy you're going to use to the severity of the disease, also to limit your exposure to steroids. Restrict your maintenance steroids, prednisone, to less than 5 milligrams per day, but he, in fact, would prefer less than 2.5 milligrams a day. If you're going to treat flares, moderate to severe flares, he recommends using methylprednisolone 125 to 500 milligrams for 3 days as opposed to screwing around with higher doses of orals. He strongly recommends the use of immunosuppressives as a way of reducing the reliance on steroids. Consider again methylprednisolone in people who are not responding to a higher dose of 1 week or more of prednisone, like 7.5 to 10 milligrams. And then you should foresee the day when you're going to withdraw steroids. He says 3 to 5 years of being in remission. Again, there are other studies saying lower amounts, like 2 years. And then he does recommend that you stop the immunosuppressive drug before you stop. So start prednisone withdrawal after stopping immunosuppressive drugs. So immunosuppressive first, or wean those first before you start playing with the prednisone. And then the taper is going to take you 3 to 6 months, but you need a plan on how to do that. Again, on our website, we feature a lot of lupus this month, including Petrieisms. These are famous things that the great Michelle Petrie has said. Here's a few. Hydroxychloroquine is lupus health insurance. Next, the P in prednisone stands for poison. Next, never argue with the chart. Call the doctor to resolve an issue. And lastly, the diagnosis of lupus is not a gift. The patient has to earn it. We had a fabulous Tuesday night rheumatology this past week with Brad Rovin and Rich Fury talking about pivotal articles in lupus nephritis. Next week, upcoming Tuesday, we have the world's leaders in cutaneous lupus. And this includes Dr. Victoria Worth, Matilda Nicholas, Anthony Fernandez, and Christopher Richardson. And they're going to be talking about key issues in the diagnosis and management of cutaneous lupus. That's Tuesday night rheumatology. Be there. Take care.